Here are a few brief excerpts from the Infuse training presentations.
As we look at the intensive care unit, there are multiple things that you will find in a patient room in the intensive care. The picture that you see here gives you pretty much a true picture of what your average intensive care patient and all the equipment will look like. So as we look at the picture, you see the nurse on the far side of the bed. They may be working with IV tubing, they may be working with catheters on that patient. We will be looking at how blood gases affect respiratory metabolic status and how to interpret those blood gases. So with respiratory acidosis, the CO2 is greater than 45, the pH is less than 7.35. So I have a high CO2 and a low pH. Both of those are indicators of acidosis. This is associated with alveolar hypoventilation. If you remember a little bit ago, we talked about if you are not breathing adequately, if you're not blowing off the CO2, then your CO2 rises and that can cause you to be more acidotic. And the metabolic function indicator is bicarbonate. So CO2 is acidic, bicarbonate is a base. Acidosis, our pH is too low. Alkalosis, our pH is too high. One way that we can analyze ABG results, number one, we will look at the pH. Is it acidotic or is it alkalotic? Then I need to look at the PaCO2.
There is dilated, hypertrophic, and restrictive. When we talk about cardiomyopathy, it's a subacute or a chronic disorder of the heart that affects the structure and the functional ability of the myocardium. If you remember about the pathophysiology and your anatomy of your heart, you have that myocardium that is surrounding the heart. So we've talked about dilated cardiomyopathy and signs and symptoms to watch for there, hypertrophic cardiomyopathy, and the last one is restrictive cardiomyopathy. Restrictive cardiomyopathy is the least common of all three of these cardiomyopathies. It's characterized by a restriction of the filling of the ventricle.
Today we will talk about different roles and responsibilities of the nurse, different imperatives that the nurse needs to have to be able to function well in the emergency room, to function with coworkers, to function with patients. And we'll talk a little bit about the history of the emergency room as well. So let's look first at nurse-patient communication. Nurse-patient communication can carry or have many different models, many different aspects that are looked at. But the one that we're going to look at today is the Bear Institute model. And it is a model that looks at 4 different components. The nurse-patient communication involves engaging the patient, empathizing with the patient, educating the patient, and then enlisting the patient. And we're going to look at these individually. So as the nurse is looking at the patient coming into triage, they're looking at the vital signs, looking at the patient's history, the problem that they come with, and they take the 5-level instrument and they are given instruction on how to place that patient as far as levels of acuity or priority of care. Who needs to be seen first? Who can be seen later? Who needs to be seen in trauma? Who can go to major care? So these triage instruments give the nurse the information to make those decisions. So let's review the nursing process just quickly. The nursing process has 5 components. 1, assessment. 2, nursing diagnosis. 3, planning. 4, implementation. 5, evaluation. And this is the process that a nurse goes through in caring for the patient. Now let's talk about some different types of shock. A definition for shock can be complications that result from a loss of adequate tissue perfusion. There are 4 different types of shock that we will discuss. The first is hypovolemic. The second is cardiogenic. Third, distributive. Fourth, obstructive. And we will look at causes and pathology behind these different types of shock. And as you refer to your notes, you will see that there are different stages of hemorrhage or different classifications of hemorrhage. And they classify from class 1 to class 4. And dependent on the volume of blood loss that has occurred, the symptoms will increase in severity.
We're going to be talking about acute coronary syndrome. Acute coronary syndrome has 3 subpoints underneath it. There are different types of coronary syndromes that we're going to look at. The first one is an acute myocardial infarction with ST segment elevation, or what we call STEMI. This requires immediate reperfusion because of the blockages that are in the coronary arteries. The second is what we call a non-STEMI, or a non-ST segment elevation with positive cardiac markers. And then the third section underneath acute coronary syndrome is going to be unstable angina. This has negative cardiac markers, but the patient presents with a acute coronary syndrome. So every time the left ventricle squeezes and pumps the oxygenated blood through the aorta, right connected at the arch of the aorta is the coronary circulation. That is the vessels that feed the heart directly.
The next type of surgeries that we'll talk about are ventricular surgeries. Now, these are the surgeries that we referred to earlier that would fix a hole or a defect that is in the septum. If you have a defect in the ventricles, blood will come into the right side of the heart, the right atrium, down into the left ventricle, and blood always follows the path of least resistance. So the blood is going to go where the pressure is the least. The pressure is greater on the left side of the heart than it is on the right side of the heart. So if you have a hole between the 2 ventricles, as the blood pumps, oxygenated blood from the left side of the heart can come over to the right side of the heart. And you may think, well, why is that a problem? That problem is that it decreases the oxygen that is going out to the body.